Great. Okay. Well, hello everyone. Good morning. And so it's my pleasure to be here, and I'd like to, thank you for the opportunity to present at Vector's Research Day. So the first one of the academic year. As Danielle mentioned, I'm a clinician scientist. So I look after patients 25% of my time, and 75% of my time is dedicated to research that is really inspired by the care of patients. So specifically, my role is to evaluate patients for liver transplantation. So those who have end-stage liver disease due to different causes. And that can be due to fatty liver disease, alcoholic liver disease, hepatitis, autoimmune hepatitis. So there are various causes of liver disease. I take them through the process of evaluation and candidacy for transplant, take care of them around the time of transplant. So I don't do the surgery per se, but I actually do everything else around, including the immunosuppression. And I have the opportunity to look after them in their second life. So the reality is that our patients are very sick going into transplant. We don't have dialysis available. So the liver is the one organ for which you don't have any machines that can replace the numerous functions. So there are over 500 functions that the liver performs. It is quite the silent metabolic factory working 24/7, but is often underappreciated. And so post-transplant, I then look after 350 patients in their second life, as I mentioned. So it's really, it's really an opportunity to take care of patients when they're, really at end of life, and then take care of them post-transplant, which is their lease on life. So that experience really has informed the projects that I'll talk to you about today. These are my disclosures. And I run a translational research team, which is comprised of computer science graduate students and postdocs co-supervised with colleagues in computer science and who are Vector Institute members. And additionally, I have clinical trainees whom I often will pair up with the computer science trainees so that they can learn from each other. And additionally, I'd say there's also, I value to say shadowing a clinician to really understand what problem is inspiring that specific question. And in fact, some of the trainees who have done the work that I'll present actually have shadowed me in the clinic to understand the inspiration for the question, which I think is quite critical to then informing certain novelty and methodology that will suit the nuances of the clinical question. Okay, so in terms of how I got involved in this, so my PhD was in medical biophysics. And so I did both wet lab and bioinformatics training during my PhD, so it did not involve computer science. But then in 2017, as I was in my second to last year of PhD, I started hearing a lot about AI. So I read those papers on diabetic retinopathy recognition, skin cancer recognition. And I thought it would be very interesting to look into the application of such methods to the kind of data that I was seeing in my day-to-day practice. So in liver transplant medicine, or in liver medicine in general, we often look at different patterns in the data. So I often find myself looking at, say, patterns, ALT greater than AST. So alanine aminotransferase greater than aspartate aminotransferase. These are enzymes that are released when liver cells die. Okay, so you see that when the liver is inflamed. Alkaline phosphatase, often elevated when there is bile duct injury, but then, there are various causes for this. But that specific pattern and changes in those patterns over time, actually we look at subconsciously. And then we look at the age, the sex, the comorbidities of the patient, whether they have diabetes, chronic kidney disease, what was the reason for their liver injury. So we look at all of these things and we, sort of generate individualized predictions for the patient. Then we look at, imaging data, other types of data, histological data. We consider environmental exposures, et cetera, their immunosuppression if they're post-liver transplant. So we're looking at all of this data and we're trying to generate a personalized prediction for the patient in front of us. The reality is that it's very difficult, as you all as computer scientists would be aware. It's very difficult to actually, for the human brain to really integrate all of these different types of data and generate such individualized predictions. And so that really was what inspired me to look into adoption and development of novel methodologies in transplant medicine, and also deployment of such tools. So my group has published some reviews in this regard, so applying ML to liver disease and transplantation, and some other review papers led by clinical trainees along with computer science trainees. You can see these listed here. But really, it's quite complex, the kind of medicine that we practice in transplantation as compared to the general population. So these patients are, there's so many different factors that we're trying to consider in order to generate certain predictions. Additionally, there's a lot of dynamics. So if you look at, for example, the liver transplant waitlist, we will list patients with a certain liver severity score, so which we call the MEL score. So the MEL score is the model for end-stage liver disease. So this is a score that was developed at a time when hepatitis C was the dominant indication for transplant back in 2002. So it's a mathematical functional form, Cox proportional hazards model that considers initially 3, but 4 blood tests. So the INR, creatinine, bilirubin, and sodium of the patient. And these are all reflective of the severity of illness. But the reality is that the score at which you list a patient is not the score at which they will be transplanted very often. So there will be dynamics on the wait list. When the liver is stressed by an infection, for example, patients can go into what's called acute on chronic liver failure. So they can have very rapid changes in those blood test results within a very short period of time. And intuitively, the clinician knows that actually their MEL score at week 2 into that presentation is not actually reflective of their risk of mortality. We know that it's actually higher. And we've, as a community, we've often thought, oh, we need to place higher priority for such patients because they are actually much sicker. But it's not possible to do this, obviously, because we're stuck with this particular mathematical functional form, the MEL score. But intuitively, very rapid changes within a short period of time actually increase the risk of dying on the wait list. And as I mentioned, we don't have dialysis. So these patients, either will pass away or they have very high priority for the for the organs available. And, these dynamics, the opportunity to model the dynamics in these blood tests and other parameters would be very helpful, intuitive. Additionally, we have various decisions that we make in transplant that can be subjective. So there is some degree of subjectivity that can come into play. There can be interinstitutional variability in decisions made around candidacy for transplant, or donor-recipient matching, choosing proper organs for transplantation. There can be inter-individual variability and there can be inter-institutional variability. So I did my transplant hepatology fellowship at Mayo Clinic in Minnesota. And then I came back, I'd done training at McGill University, and then I came to Toronto. And I can tell you that there was variability in practice across the different institutions, whether it comes to candidacy for transplant, what kind of post-transplant care we offer to patients. So there is some variability. Now, when you're talking about life and death decisions, day to day, we make life and death decisions. Okay, so these are critical decisions. And, even though we discuss cases as a committee, we have 12 people on the committee. So hepatologists, surgeons, social workers, anesthesia, cardiology, psychiatry. So you have a whole number of people on the committee who are trying to make as objective a decision as possible about a patient's candidacy for transplant. And we're doing this with, say, the combined expertise of everyone represented. So some people have been practicing for 30 years, others have been practicing for 10 years, but we're all trying to pool together our experience in saying, okay, well, this patient is suitable as a candidate for transplant. But the reality is that, say, one surgeon's, recent adverse experience in the operating room may influence his or her decision as to whether this patient is suitable or not. So there is some element of human, recency of exposure or recency of event, that could influence subconsciously what they say in that committee meeting. And then sometimes there are some voices that will be louder than others. So, so there is some possibility for bias, right? So, of course, we are I'm not saying this to kind of, cast aspersions on the decisions that we make, because I would say, at UHN, for example, we do over 200 liver transplants a year. So this is, the largest program in Canada. And certainly in North America, until last year, we were the largest program in North America for liver transplantation. But the reality is that there are certain decisions that, it may not be 100%. But then who is to say what is 100%? Because say Mayo Clinic or another US center is probably going to be much more conservative than we are, because we are in a public healthcare system, whereas they are in a, private driven healthcare system. So there's more of the capitalist, approach to care, right? So quite different. So how can you use AI as a co-pilot for these complex decisions? So I think, that really also inspired, the potential applications. And so this is a review that I published with a colleague from Mayo Clinic in Journal of Hepatology last year around AI and liver transplantation. There's the opportunity, again, as I mentioned, to bring objectivity to donor-recipient matching. This is an AI tool that had been published 10 years ago, actually, an artificial neural network model to predict graft survival based on donor-recipient match with an AUC of 0.8. Unfortunately, this model did not externally validate, and there was some issue with prospective assessment of this tool, so which often does happen, as you would be aware. This is from a colleague of mine, so Andrew Sage and Shav Keshavji, along with Bo Wang, had co-published this paper developing an AI model to assess for organ health. So organs that are subjected to a specific technique called ex vivo lung perfusion to resuscitate those organs and make them transplantable. And so this particular model considers various donor features as well as features on the pump or on the perfusion machine to then predict what is the potential for the organ to work successfully post-transplant. So they were able to demonstrate excellent model performance and basically have been working to deploy this algorithm in the clinical setting. Additionally, this is another tool that is out there, and obviously a very successful group. So Alex Lupi in the Paris Transplant Consortium, or Paris Transplant Group, sorry, he has developed this particular scoring system, a universal algorithm to predict the risk of kidney graft loss, considers several patient and graft parameters, and it has actually become a novel clinical trial endpoint in kidney transplantation. Okay, so now I'm going to get into some specific cases that were really inspired by my clinical experience. And I reached out to different people across the Department of Computer Science, Vector Institute, to collaborate on these projects. So the first one I'll talk to you about is a collaboration with Rahul Krishnan, who is in the Department of Computer Science and also at the Vector. And so this was work that was performed by Michael Cooper, who is a PhD student, and co-supervised by myself on this particular project. In liver transplantation, we know that there are issues around equity. So there are inequities in terms of liver transplant allocation, so organ allocation. So I talked about organs earlier and how many people can pass away on the waiting list. The reality in Canada, in jurisdictions such as Ontario, is that unfortunately, supply is insufficient to meet demand. And demand has continued to increase. So whereas hepatitis C was the dominant indication for transplant 10 years ago, now it is curable as of 2016, 2017. Now we have antivirals that can cure hepatitis C at a rate of 99% sustained virological response. So this is actually a dramatic development and, you know, has really decreased the need for transplant for hepatitis C as an indication. So the main indications nowadays are fatty liver disease and alcoholic liver disease. So fatty liver disease is also known as metabolic associated steatohepatitis, which is mainly associated with diabetes and obesity. And that represents 25% of indications for liver transplantation. Alcoholic liver disease actually has particularly gone up during the COVID pandemic, unfortunately, and is an important indication for transplant as well, representing similar percentage, maybe just above 25%. Liver cancer, which arises in the setting of a diseased liver. So when you have many, many years of exposure to an insult, what happens is fibrosis accumulates. So there's often, you may not be aware of this actually. So the liver is the one organ in our body that is capable of regeneration. Only organ that is capable of rapid regeneration. And we actually leverage this in our program to perform living donor liver transplantation, wherein you resect up to 70% of the liver from a healthy donor between the ages of 16 and 60. So it's the right lobe of the liver that is then transplanted into the recipient, and both livers grow back to normal volume by 3 months after the surgery. Okay, so we leverage this ability. There has to be a minimum liver volume that is transplanted to enable liver transplantation, but we leverage this given that we have, unfortunately, a very high demand in relation to the supply of deceased donor organs. So in our program, in fact, out of the over 200 livers we perform annually, 70 to 80 are living donor liver transplants. So these tend to be family members. There are also anonymous living donors out there who are, you know, just great Samaritans, beyond great Samaritans, who give up to 70% of their liver to save someone on the wait list. So nonetheless, in our jurisdiction, we have a 25% waitlist mortality. And this tends to particularly disadvantage women who have a 15% lesser chance of attracting an organ offer, the deceased donor organ offer. And so I was seeing this. So when I started my liver practice, you know, I was doing liver transplant ward, and I would see how, you know, there would be women who were admitted to hospital, were very, very sick. And actually their MELD score was relatively high, but it wasn't high enough to attract an organ offer. And then we would call in someone from home, and, you know, and it would tend to be a male. So, you know, we would see these unfortunate inequities, and then that person would pass away. So, you know, so I was quite disturbed by this. You know, I saw this on 3 or 4 occasions wherein a younger woman, you know, in her 30s or 40s, mother of 2 children, you know, a few children, so she has dependents. So, you know, it just seemed very unfortunate and inequitable. So as a young mom myself, I was quite disturbed by this. So I said, you know, we need to do something about this. And so this is when I started looking into the literature, and I realized that there was growing literature in this area. And then I checked whether, you know, having access to a living donor program, which is what we have here, was actually helping women to gain access to transplant. So it was true that, say, women who had access to living donor liver transplantation actually had, you know, the same chance as men, as long as they had a living donor. But that's actually not the solution to this very important problem, because many programs out there don't have living donor liver transplantation because of lack of surgical expertise. So that fundamentally was disturbing to me. So that was one issue. And then the other issue was that primary biliary cholangitis, which is an autoimmune liver disease, is also an important indication for transplant. And what has happened in this Cox proportional hazards model, the MEL score, the INR and the creatinine are highly weighted, but the bilirubin is very lowly weighted. Okay, so by a factor of 3, actually. So those who have bilirubin as an indicator of severity of disease, which is PBC and PSC, unfortunately have a much lesser chance of attracting an organ offer. So we know that, for example, a 45-year-old woman with PBC is going to be, unfortunately, compromised on the liver transplant waiting list. She will not be able to attract an organ offer, even though she is very, very ill. And she has to become deathly ill in order to attract an organ offer. But what happens is, unfortunately, she may end up dying on the wait list, becoming too sick for a transplant and dying on the wait list. So this is another issue. And then I mentioned the changes in the underlying patient cohort. Okay, so this was work. Just a second. Right. Oh, okay, there we go. Okay, so this is work, as I said, that is has been conducted by Michael Cooper, who's a PhD student. And so he has trained a model, a deep serve model, on over 53,000 patients listed for liver transplant in the US since 2016. These were adult patients with decompensated cirrhosis, and there were 13 static and time-varying covariates per patient. Now, beyond these 13 static and time-varying covariates per patient, so as I mentioned, there are changes in the INR, bilirubin, and creatinine and sodium over time on the wait list. But beyond that, he added a rate of change covariate. So velocity and acceleration of each of these blood test results at each longitudinal time point. And by doing that, actually, we got a much better representation of how sick a patient is on the liver transplant waitlist. So we call this score DynaMELT because it is dynamic. So a dynamic model of end-stage liver disease. And actually the concordance index, which is the correspondence between the rank ordering by risk score and rank ordering by time of death or censorship within 90 days, was statistically significantly higher, so at 0.818 versus 0.801 and 0.795 for the MEL sodium and MEL 3.0. These are other measures, as I mentioned, of liver disease severity. Then we looked at fairness. So there's a particular measure of fairness that Michael then used called pooled group concordance index, wherein you're looking at the concordance of pairs where the first member is part of a defined protected group, such as women or PBC. So then looking at this, we determined that women would be better served by DynaMELT, significantly better. Primary biliary cholangitis would be significantly better served, as well as small statured patients. So I didn't get into this, but most deceased donor organ offers tend to be from male donors because the causes of death often tend to be, the causes of death of donors tend to be afflicting males as opposed to females. So stroke, MVAs, etc., fentanyl overdose, etc. Unfortunately. So again, and then women also compete against pediatric recipients for the same organ. So a smaller statured woman would be competing against a pediatric recipient, and of course we would favor the pediatric recipient. So anyhow, so with our DynaMELT, we achieved a much better measure of fairness for these particularly disadvantaged patients. And then looking at relative risk trajectories with DynaMELT, you can see here that a female patient with PBC would be much better served by DynaMELT, as well as those in acute on chronic liver failure. So I talked about that, which is rapid changes in blood test results. Then we did a SHAP analysis, which I think as a clinician, I feel is critical to instilling trust among physicians. So this is, if something is intuitively predictive of an outcome in your patient, then you are more likely to trust the output of that prediction. So in this case, what was very reassuring to us as a group was that the top 5 parameters that were predictive of waitlist mortality or dropout were actually the same parameters that were being considered by the MEL sodium and MEL 3.0, which are the, as I mentioned, the scores that we use for prioritization. So creatinine, bilirubin, INR, albumin, sodium, and sex. Okay, so these are the top. And these are the most important for the overall population. However, there are specific subgroups of people, so these are all represented by points, for whom a first order change, so velocity of the serum sodium or velocity of the creatinine, albumin, bilirubin, and INR are actually quite important. And so you would be disadvantaging them by not considering those rapid changes in blood test results. And then PBC also you can see here, as I mentioned. Okay, and then so based on this, with our score, we have the opportunity to provide individualized interpretations, including what is the relative weight of this particular parameter on this prediction at 43 days after listing, at 79 days after listing. So we're not really able to offer that level of granularity to our patients at this point. And so it's not just trust that you need to build with physicians, but it's also trust with patients who are the final end users of this, right? So, and then maybe your patient then has the opportunity, they feel empowered in knowing this, and what can I do to change my trajectory? So, or what can I do to change my outcome on the wait list, right? So, so this is very helpful to patients. So we have patient partners actually involved in our projects, which is very helpful to understanding perspectives around future dashboards, etc. So that's one very important aspect of our research. I put this by mistake. Okay, so limitations and next steps. So we have been engaging with the UNOS Liver Committee in the US, as well as different organ procurement organizations across Canada. We actually have a CIHR grant, a project grant to fund this particular project prospectively. So we are gathering data from across the country, and the idea is ultimately to be able to implement this solution into practice. And so we do have very good engagement from the TGLN, which is the Trillium Gift of Life network, or Ontario Health at this point, and then the other OPOs across our country. So we are performing external validation, and then the idea would be to run some silent trial and then bring this ultimately into practice to help patients have more equitable access to organs. Okay, next I'll get into some work that is published. So that work is not published, it's under review right now, but the next pieces of work that I'll discuss are actually published. So this one is looking at optimizing post-transplant survival. And so the reality is that the median survival of liver transplant recipients is 20 years less than population life expectancy. Okay, so what can we actually do to change that? So the reason is because in the long term, our patients' outcomes are compromised by a higher incidence of cancer, because immunosuppression actually subdues the ability of your immune system to recognize cancer cells, which are foreign. Okay, so it subdues or it inhibits the ability of your immune system to recognize infection, so bacteria, viruses, but it also inhibits the ability to recognize foreign cancer cells or cancer cells. So this is why transplant recipients and anyone on immunosuppression in general, so say rheumatoid arthritis, inflammatory bowel disease, these patients have a higher susceptibility to infection and cancer. So then they also come into transplant with certain comorbidities. So they come in with diabetes, chronic kidney disease, so other issues. And so both the existing comorbidities as well as the lifelong immunosuppression increase their risk of death as compared to the age and sex matched general population. And so if we look at long-term outcomes after surviving the first year, now the reality is that 1 year survival has dramatically improved in liver transplant medicine. So from a 65% 1 year survival over 30 years ago, we've now come to 95% 1 year survival. So in 1983, the NIH determined that liver transplantation was no longer experimental. So, I mean, since that time, we've come a long way in terms of 1 year survival. But if we look beyond a year, certainly there's a lot of work we could do to improve this, because you can see here that long-term outcomes after surviving the first year have not improved. So how can we change this and turn transplant into a cure? So this was a paper we published a few years ago in Lancet Digital Health. And so I was co-senior author with Bo Wang on this one. And this was driven by, very interestingly, an undergraduate student in engineering at that time, Oswald Linsky, and then a clinical research fellow on my side, Amir Agier, who worked together to drive this project forward. So we looked at risk stratifying liver transplant recipients in the long term after transplant. So the reality is that when I see patients in the clinic, so I'll tell them, okay, well now you're 3 years post-transplant, your liver graft function looks good. And then, usually we just say, okay, please take care of the rest of these things with your family doctor. Unfortunately, the family doctor has limited experience or awareness of how much higher the risk of diabetes and cardiovascular disease is in my patient vis-a-vis patients in the general population. So they may not be as proactive about acting upon, say, diabetes, dyslipidemia, etc. So how can we personalize the care of liver transplant recipients to optimize their outcomes? Because I can say something, I can say, well, your diabetes doesn't seem to be optimally controlled. And then my patient comes back the next year and their diabetes is even worse. Maybe they've, gained some weight. I don't have any specific numbers to give them. So how can I, give them specific numbers so that they can work on this and try to work on this and improve their long-term health? So we considered longitudinal data from the Scientific Registry of Transplant Recipients, which is the large, it comprises all liver transplant recipients in the US. And so the idea was to build a more personalized risk calculator. We evaluated various deep ML algorithms to predict mortality, and a transformer model was the best performing model. So we considered longitudinal data of several variables over time. And so the best performing model, as I mentioned, was a transformer model. And given that we were looking at 5 different outcomes, the AUC was reasonable, but not stellar. So overall AUC of 0.77 for 1 year survival and just a bit less for 5-year. Cardiac graft failure, cancer, and infection-associated mortality were in the 0.80 to 0.81 range for 1 year. And this was in comparison to logistic regression, which is lesser performing here. Then we did a cross-validation with our UHN data set, so on over 4,000 liver transplant recipients, and the model was similarly performing, although the SHAP analysis showed that the overall ranked features were somewhat different for our UHN population versus the US one. So in the US one, you can see that their insurance status actually had an impact on, unfortunately, on the risk of graft failure, because many patients may lose access to it. I mean, now they have a new system to accommodate and pay for immunosuppression more broadly, but historically, many patients have then lost access to insurance, and then they don't have immunosuppression to protect their graft from rejection. So then we looked at SHAP analysis. We did a SHAP analysis, as I mentioned, to look at what were the predictors, et cetera. And now we are deploying a version of this tool into our transplant clinic via Epic. With the collaboration of Mike Rudno and team, the UHN data team. So there's a data engineer who has facilitated the flow of data from Epic to a cloud and then fed through a dashboard. Whenever we click on a specific icon within Epic, it launches as a separate window and we're able to generate personalized predictions for our patients. And so we're evaluating the performance of this prospectively and seeing how physicians are using this and how this can empower patients as well. And very specifically, we're focused on CVD risk prediction, especially cardiovascular disease risk prediction, the modifiable and non-modifiable risk factors that are predictive of outcome. Now I'll move on to post-transplant graft survival. This is very interesting as well. So in liver transplant recipients, you may be aware that cirrhosis takes 30 years, to develop over time. Again, as I mentioned, when you have any degree of injury to the liver, there is this opportunity for the liver to try to regenerate. Okay, so it does try to heal itself, it tries to regenerate, but at the same time, it activates certain cytokines that will activate stellate cells. So stellate cells are those cells that deposit collagen. So just like when you injure yourself and then you have scar, so that's collagen, okay? So there's that healing response. So similarly, the liver has that sort of healing response. But unfortunately, that healing response, it becomes problematic over time. So over time, it can evolve into cirrhosis of the liver. Cirrhosis is end stage for different causes of insult. So if you have hepatitis C or alcoholic liver disease, this is seen as an insult by the liver. The immune system acts against that insult. And in the crossfire, then you have fibrosis and then cirrhosis over time. The liver tries to regenerate, but then after a certain, accumulation of fibrosis, it is unable to regenerate any longer. And that's when we have to consider a transplant. In younger patients, so this is another interesting thing, another interesting tidbit, so in younger patients, for example, a 30-year-old has alcoholic cirrhosis, okay? They have decompensated alcoholic cirrhosis. So they have ascites, encephalopathy, variceal bleed, they're very sick. But the liver still can have the chance to recompensate because the liver is able to regenerate. And that's something many people in the general population don't understand. They assume that once the liver is done, it's done. It is not completely done, especially in younger patients, okay? And a lot of the time. That's what we explain to patients day to day in the clinic. So many people don't recognize that the liver is quite forgiving, especially in younger people, okay? So anyways, it isn't as forgiving in transplant recipients. And that's why we were interested in developing this tool to predict the progression of fibrosis in liver transplant recipients. So you have a much shorter time window to act. So it can accumulate within 5 to 10 years after the transplant. And so this work was driven by Divya Sharma, who is now an assistant professor of mathematics at York University, but at that time she was a postdoctoral fellow whom I co-supervised with Wei Zhu at Princess Margaret Cancer Center, and Amir Aji, clinical research fellow, drove this together with her. So the idea was to develop a deep learning model, and so she developed a variation of long short-term memory networks to leverage longitudinal changes in clinical and laboratory tests over time to detect significant fibrosis in liver transplant recipients. And so she considered 29 variables. And basically in the end, with exclusion criteria, we had 1,893 liver biopsies with several longitudinal data points over time that we were considering, and 29 variables. So she trained conventional ML algorithms as well as deep learning algorithms, and developed a variation of the LSTM to better handle missing data and to improve LSTM through a certain weight loss function to minimize bias. So she upweighted the cases versus the controls to better train on the cases. And so in the end, with this particular variation of LSTM, she achieved an AUC of 0.798 to detect significant graft fibrosis in liver transplant recipients. And this was much better performing than conventional risk scores for graft fibrosis. And we published this in Lancet Digital Health last year. And the top ranked features are here in terms of what was most predictive. And they were actually clinically intuitive, including recipient age, transplant primary indication, and donor age. And then so we've not yet integrated this into our EPIC platform, but it's one of the tools that we are planning to incorporate. So now I'll conclude, excuse me, with another tool that we have developed actually, and this paper is now under review. As I mentioned, many people will have abnormal liver tests post-transplant, and 25% of patients pass away due to graft failure. So there are different causes for increased liver enzymes, and so this is a multi-class problem. So 6 to 7 conditions are the most common reasons for elevated liver enzymes. We will perform an ultrasound with Dopplers, followed by liver biopsy as a gold standard for diagnosis. But this is invasive, multiple risks, and in our public healthcare system, there can be delays, unfortunately, in getting certain tests done. So the physician has a certain hunch based on patient profile and test patterns. As you can see here, this is an example, okay? So this patient, in my mind, would have a higher risk of rejection as opposed to the other reasons for elevated liver enzymes. So we looked at developing an ML algorithm trained on different pieces of data, dividing these recipients into different histological diagnoses. So the best performing ML algorithm here was an artificial neural network with an AUC of 0.866. It had a different range of sensitivity, specificity, and AUCs depending on the type of graph pathology that we were considering. This was the SHAP analysis, which again, clinically speaking, made sense. So this is, very helpful for us to see. And then we did an expert versus ML implementation analysis. So last December, we, invited our 12 hepatology, I invited my 12 hepatology colleagues. We had pizza. It wasn't just hepatology colleagues, it was like trainees as well. So transplant hepatology fellows. So we looked at 30 cases. So Divya presented 30 cases with various test patterns, clinical background, et cetera, okay, immunosuppression. And then finally, actually the ML model did better than the hepatologists in every evaluated category. But the rejection category was not as well performing. So then I asked Divya, is there any way to train this model any further? Can we feed this model further clinical decision rules that I have in my mind? Because I see that this model is making some unusual mistakes that I wouldn't make actually. So then I gave her 6 clinical decision rules, which she then inputted into this algorithm. So encoded as prior knowledge, Bayesian inference principles were applied to fuse this prior knowledge with the likelihood computed by the neural network. And this was integrated through the weighted combination of probabilities generated by the ML model and the clinician. So doing this, this AUC integrating this clinical insight, so human in the loop approach, actually significantly increased the performance of the algorithm in a statistically significant manner. And so in the end, this is a multi-class diagnostic tool. Okay, and that also we have the opportunity to implement via EPIC and prospectively evaluate in, say, a clinical trial
model. So this thing where you have 3.
And then finally, I'll conclude with the opportunity to integrate different omics data. Someone speaking or?
I'm sorry.
Oh, okay, no worries. Oh, okay. So different omics data, and so this is really pilot, so it's a pilot study, but it's integrating CFB-DIP-seq. So you may be aware of CFB-DIP-seq, which was an assay developed by Daniel de Carvalho and team at Princess Margaret. And so his team developed this as an assay to detect and screen for different types of cancer. So then, as a liver physician, I've been collaborating with him, and I thought it would be very interesting to see if different causes of liver injury might have specific distinctive methylation patterns. And so we decided to look at liver transplant recipients with different causes of injury, so NASH or MASH versus rejection. So we looked, this is still a pilot study, we did CFB-DIP-seq, ran the CFB-DIP-seq pipeline on DNA extracted from the plasma of 11 liver transplant recipients with NASH who had matching biopsies, and determined that the DMRs, or the differentially methylated regions on the circulating DNA, were associated with lipid metabolism, with lipolysis function in NASH, and then in rejection patients associated with the PDGF signaling pathway, which is also biologically associated with rejection. And so Mamatha, who's a postdoc with me and a Schmidt AI fellow, actually, integrated clinical variables. So she looked at age, sex, ALT, AST, ALP, diabetes status. So she integrated those clinical variables along with these DMRs. Now, admittedly, this is it's a small data set, very small data set, and now we are performing external validation on data obtained from patients in Hanover, Germany. So she ran a multinomial logistic regression with L2 regularization on this data set, so 70%, 30% test split. There was a nice distinction between the three different categories. And in the end, our tool was able to classify rejection and MASH with high accuracy. And interestingly, the top clinical feature that was predictive was the alkaline phosphatase, which is very interesting because in clinical practice, we know that those with rejection have an elevated alkaline phosphatase. And this is what distinguishes them from those patients who have NASH. So this is what helped me sort of trust the output of this algorithm, because everything else was a bit of, a bit random, with the chromosome intergenic regions, etc. So, having that one clinical variable being the most predictive was very helpful. Okay, so overall, I think, this whole series of research projects is really inspired by my own clinical experience. And I've had the good fortune of working with different experts who are interested in developing new methods or working on these clinical problems, which I think are quite important to improving the health of our patients. There's the opportunity to personalize as well as render the care of this complex patient population more objective and equitable. There's so many different types of data that we generate in our patients. And as I mentioned, we have such a high volume transplant program. There's so much data that we generate every day. And there's really an opportunity to distill that complexity and do a better job of personalizing care of patients. Certainly, I think prospective validation and multimodal AI is in the future. And I'd like to also acknowledge members of, so I co-lead the Transplant AI initiative, which was funded or supported by our Transplant Center, wherein we are both developing and deploying AI tools across our Transplant Center. As I mentioned, we have the opportunity really to be world leading in this regard because there are no other transplant programs out there doing this on a broad scale across all solid organ transplantations. So we have that opportunity to really lead the way in this regard. And I'd like to acknowledge key collaborators, patient partners, as well as members of my research team. And please feel free to contact for any opportunities. And I'd like to also acknowledge my group's funding sources. Thanks so much for your attention and happy to take questions.
All right. Yeah, that was fascinating. Any questions? I have a number. One question, I'll start things off and then open it up to other people is, when I see age at the top of the relevant features, but that tells me maybe, not so much as a machine learner, because I'm not sure machine learning people ever, we're not really trained to look at the data, right? We look at the score and we say, I try harder. Right. And machine learning as a field has gotten very used to problems where ostensibly you can get 100% accuracy. Right. And you were saying AUC of 77, 80, not very good. Right. But, from a data science perspective or statistics perspective, you might say, well, maybe I just don't have the right variables in order to actually come to a confident decision. Right. And when I see age up there, I think, well, age is, of course is, correlate with decline generally, right? And so it's sort of like a crutch that the model can lean on, right? And you probably don't have the I would say ostensibly you would have the features that would allow age to be irrelevant, right? Okay, I have an actual picture of your health, right? Which would allow me to look at someone who's someone who's had a very metabolically healthy lifestyle, right? And happens to have picked up HPV or whatever these diseases you were saying. I forget what the disease was that caused liver failure, right? Or someone who's been eating very poorly their whole life or as an alcoholic, et cetera, right? It seems to me at least that age would be kind of a red flag. What's the question here? I guess the question is, do you think you have the right variables to be making these predictions with confidence? And if not, what power might you have to impact what is being collected and measured so that you can make better decisions, 10 years down the line, say?
Yeah, so that's an interesting question. In liver transplant medicine, for the post-transplant side of things, if that's what you were referring to. Yeah,
I mean, I think the statement applies to all three or
Across,
four of the
okay.
projects, right?
Yeah, so on the waiting list, for the prediction of mortality on the waiting list,
Yeah.
we expressly left out age.
Yeah, okay, yeah, good
Because-
decision.
Because, well, there's a reason for this,
Yeah.
because, you know, age obviously, as you mentioned, would increase the risk of
That's
mortality.
right, yeah.
And you wouldn't want to include it in there because it could bias the organs being offered towards older individuals as opposed to younger individuals.
Right,
And we
yeah.
do have many patients who unfortunately are in their thirties and pass away, as I mentioned. So
Yes.
you don't want to we don't consider utility of the graft when we allocate organs. So really our interest is in at least 1 year and 5 years survival. So will this patient benefit from transplant, from this scarce resource, at least for a good 5 years after transplant?
Mhm.
Beyond that is not part of our decision-making, at least in Canada and the US. Now, in the US, the UNOS Liver Committee is interested in the future because patients have asked for it. Their patient partners are asking, please consider how much utility will this particular patient get out of the graft? Because reality is that, a 20 or 30-year-old who receives a liver transplant could live a good 30 or 40 years after the transplant, whereas a 70-year-old who receives the transplant may only benefit for 5 years, so they are asking for this, but the thing is, conversely, we also have to be very careful not to assign more value to one life versus another also, because so we're
But your
very
committee-
careful as
yeah.
a community, the liver transplant community, so
Yeah.
that's on the wait list.
Yeah.
Now separately for post-transplant, there is a wide range of ages that are transplanted.
Yeah.
And so the considerations for post-transplant care tend to be very different. So say a 65-year-old who had diabetes and chronic kidney disease coming into the transplant is going to have a much higher risk of cardiovascular mortality
Mhm.
or cancer in the next 5 to 10 years, as compared to the 30-year-old who was transplanted for PSC, primary sclerosing cholangitis. So that person will have a higher risk of rejection and a higher risk of dying from the graft failure or graft failure itself.
The younger person or the older person, you think?
The younger person, because their immune system is much more active. So they were
Okay.
transplanted for autoimmune liver disease. And so they have a higher risk of rejection.
Yeah.
They have a very active immune system. So
Right.
they have a much higher risk of losing their graft. So
So is
That
that an
I know
argument for, is that an
intuitive.
argument for age being in there? Cause I mean, essentially there would be I guess my point would be, there'd be another variable, which would be a measurement of activity of the immune system, which would then say, mean that the model didn't have to rely upon this, age to make a prediction.
So
as to-
probably indication for transplant could be surrogate for age.
Yeah.
Yes. But I think age in itself, so I think also, patients who come into transplant tend to be biologically or older.
Yeah.
As it is, because they have suffered from some chronic disease for some period of time. And then maybe they were a smoker, alcohol, et cetera, so they have, longer term exposure to disease. So post-transplant, when you give them immunosuppression, there's an acceleration in that some of those disease processes, including diabetes. So I think age is still an important factor, at least in the clinical sense. So it is an important factor in, say, cardiovascular disease risk assessment in the ASCVD or like other CV risk assessment tools in the general population, notwithstanding transplant. So I would include age, at least in that one, because there you're not really making a value judgment, whereas the waitlist mortality one, I think we all are reluctant to include age because there may be, disproportionately higher organs that are then offered on the basis of age.
I see. Okay. Any questions out there? Yeah.
Yes, thank you. I'll echo Danielle's comments that it's very inspiring work and
Thank
very
you.
impressive work and equally impressive presentation. I
Thank you.
personally like the fact that you have incorporated ethical characteristics like fairness, interpretability into your model.
Yes.
Now building upon that fairness aspect, so when implementing fairness, other sensitive attributes like, for example, on top of my mind, race have been considered as well, or the focus was just on gender. I won't include the age because you just explained not.
Okay. So we've not included race in the waitlist mortality prediction model, but we are looking at how this model performs in different races. At least in the US literature, there's no evidence that there's a bias once they're on the waiting list. But there is a bias in terms of referral for transplantation and then candidacy for transplantation. And those tend to overlap with social determinants of health. Same thing for the post-transplant scenario. Now, in the Canadian context, we don't collect race ethnicity data in a systematic manner. So at UHN, the one way in which I can identify race and ethnicity is to go back to the social workers note. And we do have plans to do this and collect this more systematically. But it's always been a bit of also a touchier subject in Canada as compared to the US, right? So I think this is true for any medical problem. But certainly in the US, you do see that there are disparities, especially in the referral process and then candidacy for transplant. Not really on the waiting list for transplant, because then it's the biology that kind of seems to take over. But it's a good question, and we are actually planning to assess the performance of our waitlist mortality model in, say, Black race, Hispanic, etc. Yeah.
Yeah, and the reason I asked this question is because I did my research on the readmission and I used mimic board and here I noticed there was need of fairness based on race.
Mm-hmm.
I agree with a lot of points you have raised. Thank you very much.
Yeah, I mean, are you, does anyone work with race ethnicity data in Canada?
Well, I'm not sure.
Here? Like in the vector community or?
I'm not
Because I
aware.
know with
Yeah.
ICS data, actually, it's not something also that's available, right? So people will have to self-report.
Any more questions? Yeah, please.
Great talk, thank you. I was wondering if you could speak a little bit about what you see in practice with regards to the trade-off between model expressivity and interpretability. Because I can imagine, so some of the results that you show have to do with some sort of feature attribution where you say, if the model relying on this feature in order to make decisions, but I can see that, you know, in the extreme scale, maybe when we incorporate all of the electronic health records into a deep neural network and it's making inference decisions, and we see that it performs, you know, better on some data set, the decision-making process becomes less interpretable. So in practice, what's the appetite like when you're selecting models to use in
practice?
Selection and surgery and these kind of things? How do you kind of
Sorry, what do you mean by expressivity? Can you explain
so
that? I don't understand.
essentially how complicated the model is?
How complicated the model is. Yeah.
So a more complicated model might result in better performance on some data set.
Oh, okay, this
But
is
it's
what you
more
mean.
difficult
Okay,
to
got
figure
it.
out how it's making that decision.
Okay, well, I would say, you know, if you look at the clinical community, I don't know how much you've interacted with the clinical community, but there's a great deal of skepticism, especially among more senior members of our team. It doesn't have to be more senior members of the team. I mean, in general, there's a great deal of skepticism around using AI models to guide clinical decision-making. Many people may think that they themselves, you know, have sufficient experience to make the most objective decision possible, which may be true in most circumstances. There's something to be said actually about clinical intuition. You know, there's a lot of clinical judgment, you know, subconsciously, there are a lot of, you know, thoughts or probably assessments going on in my mind when I see a patient. You know, like when I go in to see a patient, there's something about their body language or the way they look or, you know, so then it may change the way I ask questions. So there's a lot of, you know, nuance to the way we gather data and we record data. We may not record, like I may not record, okay, you know, Mrs. So-and-so told me about her son's upcoming wedding, or, you know, like I may not report a lot of things that may actually be influencing the way people respond to treatment or how they engage with health, right? So I think there's a lot of types of data that we're not collecting, but whatever we're training our models on, I think it's important to have predictions where there's interpretability, particularly to convince those who are going to be more skeptical on the team. Because otherwise you are going to have a great deal of difficulty engaging those those people, especially more senior members of the team, into using these solutions in practice. Because they won't trust it. There's a great deal of skepticism. I mean, even now, so. Yeah. And even among patients, actually. So then patients also have to consent to, actually the real buy-in we need is among patients. Not just physicians, it's also with patients, right? So they have to be willing to have this as part of their care. So do they feel comfortable with AI tools helping their physician to make a decision? They trust their physician very often. Most often, we build a certain relationship of trust with our patients. Like especially in transplant medicine. So say I know patients now I've been at UHN for 9 years. So I know people like when they were their sickest, and then I took care of them, I've been taking care of them. So then we build that, a certain relationship, right? And so there's that trust. And so they will tell you a lot of things that they may not tell the student who has gone to see the patient first, So there's a lot of data that they may provide to you if they really trust that you're doing your best. So I think physicians also will have a duty to inform patients and engage patients in their research around AI because it's a question of trust.
Right. Thank you so much. Let's give another
My
round of
pleasure.
applause for Dr. Bhat.